Very good afternoon, all. Today I will talk about tendinopathies around the elbow. My reference is from Apli and Solomon 10 edition and also Green's Operative. For today, I will talk about lateral epicondylitis and medial epicondylitis and touch a bit on distal bicep tendinopathy and baseball pitcher's elbow. So we start with lateral epicondylitis, also known as tennis elbow. It's the most common tendinopathy, and the pain arises from the origin of extensor carpi radialis brevis at the lateral epicondyle. Also, one third of the case arise from the extensor digitorum communis, which share the same origin at the lateral epicondyle. So, although the name is called tennis elbow, usually the pain does not occur, can occur without a racket use. And usually it is associated with forceful repetitive activities and also in a smoker patient. So it is actually a degenerative tendinopathy, or we call tendinosis, not inflammatory tendinitis. So it starts with a repetitive contraction, which then cause a microtrauma, and then cause a lateral epicondylitis. And later, the body and the cell try to repair by fibroblasts. Despite repair process with continued mechanical trauma, it failed to heal with normal, then it can cause tendinosis. So features of a lateral epicondylitis.
Rushdi, what's the difference between tendinopathy and tendinitis?
Tendinitis inflammation. Tendinosis chronic disease, but there is no inflammation. And tendinopathy is a spectrum of disease of a tendon, if I'm not mistaken. Okay, and tennis elbow occur in active individual, usually in 40 to 55 years old individual. They will have a lateral elbow pain and occur after unaccustomed activity. The onset is gradual, and the pain can radiating to forearm. And they also usually have elbow stiffness first in the morning, and the pain aggravated by lifting object. So on examination, there usually no swelling or may have mild swelling at the lateral of the elbow. They will have full range of motion of the elbow, and also there is tenderness over the front of the lateral epicondyle, slightly below the lateral epicondyle. So test that we can do is a pain that provoked by wrist extension, forearm pronation, elbow fully extended, like this. So when we do this maneuver, the pain will be aggravated. Other tests like resisted supination with wrist flexion, Maudsley test is pain with resisted middle finger extension, and Mills sign or chair test. When we ask the patient to lift chair, the pain will aggravated. While they're lifting a chair, there is elbow extension in pronation with flex wrist. So the diagnosis is by clinical examination. Imaging does not require unless we suspect other symptom, other diagnosis. And also imaging can be done in extreme of age, history of trauma, and also if patient have blocking symptom. So if despite treatment and the pain persists, we can do an ultrasound or MRI to rule out other differential diagnosis like painful radial tunnel syndrome, radiocapitular plica, or also PLRI, lateral ulnar collateral ligament injury. So when we do a MRI for lateral epicondylitis, there will be a frank tearing and separation of the muscle from the bone. So treatment is actually almost the same for all the tendinopathies around the elbow. So we start with non-operative treatment. After that is a operative treatment. So for non-operative treatment is a activity modification by avoiding the precipitating factor and also rest and with a spleen. Steroid injection or PRP injection also can be done. For referral to physiotherapy and occupational therapy or ultrasound therapy, electromagnetic field therapy, extracorporeal shockwave therapy also can be done. And then when the pain relief, when there's no more pain, can start physiotherapy for eccentric loading regime or stretching for the common wrist extensor. Usually the pain will relieve within 12 months in 90% of the patient. If the pain persists, we can suggest for operative treatment, which either tendon debridement can be done with open debridement or arthroscopic debridement. Comparing both, open have longer recovery time, but arthroscopic have a higher risk of nerve injury. So the tendon debridement is excision of the tendinosis area, debridement, and also reattachment of the tendon origin. If the pain with acute onset is also an indication for surgical repair if we suspect a tendon rupture at the lateral epicondylitis. So next is medial epicondylitis, also commonly known as golfer elbow. Less common, only 10 to 20% as compared to tennis elbow, but it is more resistant to treatment compared to lateral epicondylitis. So risk factor is similar to lateral epicondylitis, like smoking, and also more happen in patient that is obese, and also when patient do physical load. So pathophysiology also almost the same. It's a operative motion that can cause microtrauma at the muscle origin of at the medial epicondyle. Usually the affected muscle is the pronator teres and flexor carpi radialis. Sometimes they can also affect palmaris longus, flexor digitorum superficialis, and flexor carpi ulnaris. So it's a repetitive motion and also valgus load, such as in golf. It's a chronic overuse trauma, and if a sudden traumatic episode also can cause avulsion of the pronator teres origin. So the features is tenderness over the medial epicondyle, slightly distal over the pronator teres and flexor carpi radialis. Provoke the pain is by resisted forearm pronation with resisted wrist flexion. So differential diagnosis towards a medial epicondyle is ulnar nerve entrapment, medial ligament injury, pronator syndrome, cervical radiculopathy, elbow synovitis, arthritis, and osteochondral defect. So with patient come with a medial elbow pain, we have to rule out other causes also. So on examination, we have to evaluate ulnar nerve because ulnar neuritis also is a common presenting symptom. We have to check the cubital tunnel sign, check cubital tunnel compression test, and also do elbow flexion test. And MCL status, we have to do a valgus test and also milking maneuver. Milking maneuver is lifting the forearm upwards, and the pain will have a pain over the middle elbow. So also radiograph is not necessary. More necessary, we can also, sometimes we can see calcification adjacent to middle epicondyle, and sometimes they have traction spur. And MRI is only indicated if to rule out other condition, the differential diagnosis condition. Treatment is the same as the lateral epicondylitis. We start with non-operative treatment and then surgical treatment. So one or two slides on distal bicep tendinopathy. Distal bicep tendinopathy occur in individual around 40s to 50s who goes to gym to lift weight. They will have anterior elbow pain, and pain will reproduce on resisted forearm supination. Treatment is non-operative treatment with modification, lifestyle modification and rest. And treatment for surgical treatment is debridement and tendon reattachment for tendinosis. While baseball pitcher elbow is a vigorous repetitive throwing, happen in a vigorous repetitive throwing like baseball player, they will have damage to bone of the soft tissue attachment. In adolescent, there will traction apophysitis of the middle epicondyle, also known as little leaguer's elbow. Treatment is by rest and avoid pitching. The pathophysiology is because of persistent valgus strain. Then we'll have a middle contralateral ligament attenuation, and then will cause a posteromedial impingement, and then they will cause a valgus extension overload. So the treatment is by arthroscopic debridement and medial ligament reconstruction. That's all.
Rushdi, can you give us an overview of how do you approach, examine, and what are the investigation of choice and treatment for patients presented with elbow discomfort?
So on history, we have to take then we have to ask the which dominant hand, the work, and so the age, and then if any activity that the patient done recently, a new sport, or whether the patient went to do some activity that is new, and then ask the patient where's the pain, medial or lateral or anterior, and what aggravate the pain, and what can relieve the pain. And then on examination, you check any swelling or any redness around the elbow. Check for local tenderness, point tenderness, whether it's at the lateral epicondyle or medial epicondyle or anterior elbow. And then do a provocative test, and also rule out differential diagnosis like ulnar neuritis. Check for also any crepitus or bony cessation at the elbow. And distal check also to lateral, also lateral elbow pain, also we have to rule out the supinator syndrome, the sensation over the pain over the radial distribution. And then depends on the symptom, whether X-ray is indicated or not. And if we suspect more than that, we can do a MRI.
How about your PLRI? How do you test for PLRI?
It's by clinical examination is by varus test.
Virus test? What we call it? And anyone?
There is a laxity over the lateral of the elbow. And then,
is there any maneuver? What is the pivot shift test for elbow?
with patient lie supine, affected arm overhead, forearm is supinated.
Macam mana?
With forearm supinated, while patient in supine and affected arm overhead. So, and then with forearm supinated, valgus stress is applied while bringing the elbow from full extension to 40-degree flexion.
So what do you notice? Let's say a patient having posterolateral rotary instability.
They will have a tricep tension will reduce. The radial head will reduce.
Radial head. You can feel the radial head subluxating. Patient complain of pain.
Usually do in a anesthetized patient.
Okay. Okay, the treatment, lateral epicondylosis or litis. So mainly we 90% is, as you mentioned, is conservative. We send for physio. Another thing that I would like to add, you can prescribe patient for bracing, and the forearm bracing. The brace will wrap around your proximal forearm and will shift the center of traction of the tendon, and then the tendon proximally is more relaxed and reduce the inflammation. Pernah tengok forearm bracing or guard?
Forearm, elbow atau forearm saja?
Dekat forearm, proximal forearm bracing. Dia ada macam strap.
Oh, yang dia macam band
on
dekat
the muscle, dia macam band, yes.
Pernah tengok. Sampai yang pasang dekat lutut juga.
Yes. Okay. Surgical treatment, of course. Before you proceed, sometimes you like to try PRP or steroid. Nowadays, they're using ultrasound guided injection where you can put at the incision without damaging the tendon. And other than that, under pain protocol, sometimes we do a corticotomy around the incision with ultrasound guided. And then surgical treatment, you do open debridement one. You debride the incision of the tendon, the ECRB, the communis, and of course, you need to explain to the patient the risk of the early risk of reduced power of your wrist extension through debridement. So most of the time, patient is okay. But now, the big debridement of the tendon. The risk of nerve injury, of course, there's a risk of injury, particularly because of your medial tunnel as well as the superior lateral. The medial, you might damage the ulnar nerve. That's your viewing portal, and then your working portal on the lateral, you might damage the posterior introosseous nerve. However, the landmark will be slightly higher and more superior to your radial head. Other thing, yang tu je lah. Ada any question?
Well, I'd just like to summarize what Boss and Rushdi presented. So if patient presented with elbow discomfort, first you must determine where is the location, either anterior, medial, or lateral.
Yeah.
Okay. Next, you need to determine whether the patient is having pain or having instability. Okay.
Yes.
And for pain, you need to determine what is the cause of the pain. Is it mechanical pain, nociceptive pain, or neurology nerve type of pain? Because the differentials are different. Okay. So
Yeah.
as for medial and lateral epicondylitis per se, this is diagnosis through examination only and clinical findings. So no other investigations are needed. However, if you have other differentials such as the infection, nerve type of pain, or instability in mind, probably you need to do a pain radiograph as your investigation of choice to rule out emulsion fracture or others more sinister causes. And then for treatment wise, it will be the same, not like what those mentioned.
Okay, of course, you need to get the what the main complaint of the patient kan, because you like to divide the pathology into extra-articular or intra-articular, right? Sometimes your contoh and you kena divide into the side of the pain kan. Contoh kalau dia ada lateral elbow pain, it could be intra-articular or extra-articular. Extra-articular means sometimes because of the tendon, tendinopathy. But it can be intra-articular as well. Kan, your articular surface of your capitulum and radial head, and then sometimes there is a, you know, your what ligament is that? They entrap in between your radial head and the capitulum. Annular ligament, thicken of the annular ligament and entrap in between the head, and that can cause pain as well in the patient with lateral elbow pain. It's similar with your medial as well. You need to classify which side of the pain, and then is it the extra-articular or intra-articular. Let's say intra-articular, you need MRI to evaluate the finding. And then because kadang-kadang you ada PLRI kan, and then you need, and the scope, let's say intra-articular scope is quite gold standard nowadays, to see the tendon, to see the ligaments, to see the articular surface of your radiocapitular articular surface. Okay. Okay, dah.
Okay, thank you, boss.
Thank you.
Okay, dah.